So we can make sure we mute folks. Hello, everyone. See, I'm still admitting people in. Are you admitting too, Cara?
Mm-hmm.
Okay. Hello. Hello,
Hey.
everyone. Hi,
Hi.
everybody. We're just trying to get everybody in before we get going.
Hi, Cassandra.
What time is it for you, Joanne?
Me?
Yeah,
It's 8 o'clock at night.
that's what I figured. It must be somewhat late in the UK.
That's not too bad.
Well, it's fine. It's not, I'm not going to bed quite yet.
It's lovely to see your smiling face.
Yes, we have international folks here with us. It's wonderful. Libby just joined us.
So before Alicia gets started, I want to say welcome to everybody. I'm Cara. I started Right to Know with Alicia and Gregory, who I don't think will be joining us today. And I just wanted to make it very clear that we are recording this webinar for public purposes. It could be used for promotional purposes or for media purposes. So if you guys want to all mute yourselves, that'd be great. If you do not want your face, on the news or in a show or to be used anywhere, please go ahead and stop your video. You can change your name to something else if you want, if you don't want your name public. So I would like everybody, if your video is on, please nod that you understand that this could be used for public purposes. Thank you. We appreciate that. We don't want any misunderstandings later in the future. I know a lot of us aren't out completely in our MPE journey. Thanks, Alicia.
Thank you, Cara. Thank you, everybody, for joining us. We're very excited to be able to put this particular webinar on. We have some special guests with us. So before I get started introducing the very first guest, this particular webinar is special to me. So personal with the journey that I have gone on as an NPE. In 2014 is when I did my DNA test, and of course, as many of you know my story, and many of you have in your own stories have had the same reaction, the gut-wrenching, your heart skipping several beats after you find out what has happened, and you're looking point blank at a computer screen, and you realize your whole world has just changed completely. It takes you down. You're getting ready to start a new journey that you never ever thought you were ever going to be on. It took me a very long time to find my family. I found them in 2017. Actually, what's interesting about us doing our webinar today was this was the week that I talked for the very first, this day actually was the day I talked to one of my new half-brothers. It was from this day 4 years ago. A few days prior to that, I found my family through, of course, the DNA finding, but what sealed it for me was my Facebook search. When I was very close to finding the family, I pretty much knew this was the family, was my first cousin's granddaughter. I found them on Facebook, of all places. As all of you know, Facebook is a place to go to, isn't it, to find family and see pictures. I saw this little girl, a teenager really, and I was looking at her picture and I realized she looked exactly like my son, who has severe autism. When I realized this, I was basically in shock. I knew my son's autism was caused from a deletion in his genes called NRNX1. And that particular deletion causes, it's a missing, I think Brianne probably knows the term for better than I do, but it's actually a missing protein or something on chromosome 7. And when I realized, when I was looking at this little girl and I knew this was my family, that she looked exactly like Luke, and she also had autism. It just was like another, it hit me so hard in my heart. I was so brokenhearted because I realized this new family, really my family all along, was suffering with neurological issues. My story goes even further than that in regards to later, as I did the family trees of my new family, I realized I was in a situation because of my own history, medical history. I had a massive brain tumor in 2011 removed. The impact of that was very difficult on me. It took me almost a year and a half to recover from it. I had a stroke with it, and many things happened with my health because of it. As I was doing the tree with the new family, I found every tree I'd go down with my family tree, looking at family, I was interested in the history and where they went with their lives. And when I began to know more about them, I found I had 4 other cousins that had brain tumors as myself. Two of them beside myself are alive still. The 3 female are living. The 2 men that are were my cousins have passed away from their brain cancers. When I realized all this about my medical history, it just wiped me out. I was mentally, physically, it was hard to explain when I was looking at that, what was happening. And that if I had known this information, where would my life have gone differently? What would I have done possibly differently? Would I have had children? There are so many things that I look back now at, and you cannot question things the way they are. You have to just move on with your every day, with one step at a time, every day, one day at a time. But it brings tears to my eyes thinking about like the what ifs. In each family tree I looked at, there was an older gentleman also with autism. I actually got to know him, and he has suffered his whole life just with getting jobs and so forth. He's in his 60s now, and his story also, it just melds in with mine because of all this. It was on both sides of my dad, my maternal side and the paternal side, the grandfather and grandmother side. So this was a very sad situation for me. The autism, of course, too, as we learn more about autism, many people still they believe it's something from the environment. I have never thought that about my son, Luke. I have felt it was genetic, and the test we did prove that he has this particular deletion. The deletion also, because he had it, the way the doctor explained it to me, and it's something Brianne probably can touch on also, was that this particular deletion could be a problem that it is passed down from the parents. I probably have it, and more than likely, maybe my ex-husband had it. One of us had it, we passed it on. I believe it was me. In doing the work on all this, as I studied more and more about the DNA, the genetics, everything involving our stories, this became the most paramount thing that my heart just hurts for. We need to share more about these stories. Brianne began working. I don't know exactly when you started your work in this field, Brianne, but I know you've been doing this for a long time. Brianne is a genetic counselor and a DNA consultant, and actually she's my DNA consultant. She's also the founder and president of Watershed DNA. Brianne, why don't you go ahead and begin?
Sure. Thank you so much for sharing your background. I think the passion for your reason for pulling everybody together today for this discussion, it really shines through when you tell your story, because I know this is really personal to you, and not just to you, but to all of the people that you've run into in your life after making your discovery from your DNA test. And you mentioned that your son's testing identified a deletion, and he went through a medical genetics clinic and medical test to have that kind of information. So there are multiple different types of genetic tests, and I'm going to briefly talk about that today. But before I get started, in general, DNA is a language. It's another language like Spanish and English and sign language. There's information, and how we get to that information, it takes time and learning and focus and having help along the way from people who know this, have studied this longer than you maybe have. And so I think it's great that you brought everyone together today. I started out in medical genetics. 2005 is when I started in the professional sphere of genetic counseling and did medical and research genetic counseling for a number of years before I got interested in genealogy and the genetic genealogy aspects of testing for my own family's reasons as well. So one of my grandmothers was raised by her maternal grandparents, not her parents, after her mother passed away from complications of childbirth with a younger sibling, and her father kind of split and left the kids with the grandparents to be raised. And so there was a schism in our family. And when I started to notice, we don't have full family medical history from that branch of the tree. We don't know if there are family members out there that are part of our genetic family tree that we're not aware of. And so out of my own personal interest to kind of answer questions for my grandmother and that side of the family, it just came to be that it was the right time for a genetic counselor to be in this area and working and available for people who have questions. So that's kind of how I came to be. And I'm talking today specifically about what connects us to our origin story, to where we came from, and is it nature or is it nurture? And the long story short is the more we learn, the more we realize it's not one or the other. Both nature and nurture are important. So any time in the future when you hear that brought up, is it nature, is it nurture? It's both of them. And why is DNA a part of these discussions? Even though, we may not be connected with all of the genetic or biological family in our lives, we still have that question and that search, and sometimes a DNA test holds that answer. So when people are interested in DNA information, I see it falling into three buckets. So people are interested in DNA testing because of the connection to other people, family, relatives, maybe family they know is out there and they've lost touch with, or surprise family members sometimes happens. Another thing I see happen is people are really interested in DNA information that will help them with understanding their identity, what's their place in this world, specifically, especially with ethnicity, that pie chart of what percentage are you from each region of the world. That was a very successful marketing campaign by the DNA testing companies, that you can find out more about your roots and who you are by figuring out your percentages of DNA. And then the final one, which is what we're going to focus on today, is the interest we have in understanding more about the DNA information that encodes things for our health or just our personal traits. And it's not just for us. Many times we're curious for our children or any future generations in the family. So these are some of the more common DNA tests that people are familiar with, the ones that I speak with a lot now. And these are the companies that we refer to as the at-home DNA test companies. These companies each offer a little bit of a different kind of test. They all offer the ability to match with DNA relatives if you choose to opt into that feature. They all provide you with information about your genetic ethnicity, but if you tested all of the companies, you're going to find out that every company tells you a slightly different story about the ethnic past that you have. And it changes over time as well. And all of these companies actually are also starting to give you medical information. 23andMe always has. And then Ancestry DNA and the other two as well, Family Tree DNA and MyHeritage, have begun to offer deeper insights beyond the family, beyond the ethnicity. There are other kinds of tests that are not on the at-home market, but are what you would go to, a medical office or work with a genetic counselor or a doctor over the phone to have medical grade testing that tends to be more focused, more individually specific, less likely to have gaps in the results, and so those types of DNA tests, it really helps to have a genetic counselor involved. Along with these at-home tests as well, they all incorporate genetic counselors to different extents. But especially for a medical grade test or a medical clinic-based test, a genetic counselor is a really great partner to have. So I spend a lot of time explaining what are genetic counselors and what do genetic counselors do, because unless you've had a reason to have an appointment with one, you may not know what does a genetic counselor talk with you about. Well, it turns out that genetic counselors, we do talking, but we also do a lot of question asking. We are trying to find out everything we can that you know about your family's medical history, your family tree. We ask detailed medical history questions for you and for your children. And we also want to find out, what are your goals? What are you hoping to get out of testing? Because it's not the same for every person, and that might influence which test we recommend that you have and how we interpret those results when they come back. Different genetic counselors specialize in different areas of genetic counseling. So Everett's going to speak after me. He's a cancer specialized genetic counselor. I was once a prenatal genetic counselor, so I specialized in work with families that were planning or expecting a pregnancy. And so what test you have depends on where you go and who you talk to. But in general, genetic counselors ask a lot of questions, and the reason we do that is we're trying to pull together everything we can to give you the most accurate information specifically for you. And that's because we've realized that it's not just the DNA test, and it's not just the family tree or the family medical history that's important. It's both of them together. It's the nature and the nurture. Because each person is unique and your genetic code is not identical to anyone else in your family unless you have an identical twin. But we've also learned that even identical twins have slight minute differences in their DNA. You are an individual. And whether we can understand your risks for conditions like diabetes, which is considered a complex disease, versus the risk of being a carrier for a condition like Tay-Sachs disease or cystic fibrosis, which are recessive. We can't just look at the family tree and know everything from it. We also can't just do a DNA test and know everything from it. So both nature and nurture, both the family history and the genetic testing are helpful. So what do you do if you know you need or want a DNA test? Do you go the at-home route? Do you go the clinical testing route? Do you try to do both? And the way that I explain this is think of all of them as tools in your toolbox. You can't do everything with the screwdriver and you can't do everything with a hammer. You need the whole set to really understand. So there's value in the at-home tests, and there's also value in the clinically based test. This is a particular company, Color, that kind of straddles the two. You order this test from home, spit in a tube like you do for 23andMe or Ancestry, but there's a genetic counselor or an ordering provider involved in that process, getting the test ordered, getting the sample sent to the lab, and then getting the results back to you and explained to you. The at-home tests do have some limitations, and I wanted to point out the fact that even in the fine print, 23andMe says repeat their test. The blue line there says results should be confirmed in a clinical setting before taking medical action. So even the companies that are offering at-home tests are acknowledging that it's not the same as what you would get through your physician. So really try to partner with a genetic counselor or somebody who has additional training in medical genetics to make sure that you're getting the right testing for the reason that you want to have the testing. So like I said at the beginning, DNA is a language. Don't expect to understand it all at once. Everyone is a beginner at some point. I was a beginner at one point. And take the time and partner with someone like a genetic counselor who can help you get the most out of testing when you decide to do it. So I'm going to turn the screen over to Everett, and he's going to go through some cases. He works in the cancer setting and has picked some really great cases to exemplify these points in further detail. So, and then after that, I think we're going to have a Q&A period of time. So if you have questions for Everett and myself, that would be a great time to ask them.
Thank you, Brianne. All right, so looks like I'm trying to share my screen here. Is everyone able to see my screen? No?
Not yet.
Okay, it looks like Brianne is still sharing her screen.
I can see your screen. This is Arlene. I don't have a video up, but I'm looking at you, so some of us are seeing you.
I've stopped sharing.
Okay.
So, yeah.
Still nothing?
I'm not seeing it. No.
I'm getting a lot of glitching on my screen as well.
Let me see. Oh, there you go.
There. I see it.
We can see it. Thank you, Everett.
Now you go.
Okay. Doesn't everyone just love technology? You just try over and over again and then it works. All right, thanks again, Brianne. Thanks, Alicia. And really, my connection to this talk is, you know, I wasn't intimately involved with Alicia's care, but, you know, she mentioned her cancer history, and I was part of the care team that was, you know, involved with Alicia's brain tumor history. And my colleague saw her at Seattle Cancer Care Alliance, and she reached out to us to try to get some clinical expertise, perhaps to get some case studies as part of this presentation today. Like Brianne mentioned, I'm a cancer genetic counselor, so I'm kind of specialized within high-risk groups that are at risk or already have a cancer diagnosis. And that's really my two main roles at Seattle Cancer Care Alliance are both prevention as well as seeing patients whose genetic testing results could impact their current management. So that could mean changing medication therapy or perhaps something like a prophylactic surgical option for recently diagnosed patients. The prevention clinic I work in is called the GI Cancer Prevention Program, shorthand of GICP. And we see a variety of GI cancers, things like esophageal cancer, pancreatic cancer, small intestine cancer, and stomach cancer. I work as part of an interdisciplinary team. So, you know, we involve a nutritionist, a gastroenterologist, and we all kind of work in tandem to try to think about how to provide the best care for patients without a cancer diagnosis. So these patients typically have a strong family history of cancer, and we're trying to prevent that same cancer in the patient, given, again, strong family history or something like a gene with a cancer risk. being passed down in the family. And, you know, in general, we think about red flags in the family history and personal history that give myself as a cancer genetic pause, that make us think that there's a higher chance that there could be a gene being passed down in the family. And when we see multiple cancers under the age of 50, we see rare cancers like pancreatic cancer and ovarian cancer. And we see particularly rare pathology associated with certain cancers. You know, taken together with polyps or other precancerous findings, these red flags really make us think that there could be a gene that's being passed down in the family with a particular cancer risk. And you have to think about this in context of all cancers, because most cancers are considered sporadic, meaning that there is no identifiable gene and there's no real family history either. But when we do genetic testing on families with both a family history of cancer, we don't always find the gene involved. So what we're left with is really a description of what's called familial cancer, where we see a family history of cancer, but we have not yet found the gene. Just some pop culture references for both hereditary cancer and early onset cancer. Angelina Jolie was found to carry the BRCA1 mutation after her mom was diagnosed and passed away from ovarian cancer. She then elected to have a prophylactic bilateral mastectomy, so removal of both breasts, to reduce her breast cancer risk. She later also had her ovaries removed as well. This is aptly named the Angelina effect. We saw a vast increase in the number of referrals for patients who have a family history of breast and ovarian cancer after this happened. And it really spurred a lot of interest in this field, and particularly cancer genetics. I think a really good recent example of early onset cancer is Chadwick Boseman. He was diagnosed at age 39 and passed away at 43. This is a very young age of onset. However, we really don't know if there's any family history because it was kept secret. And that's part of my talk, is really about genetic testing in the context of family history, because these two concepts go hand in hand. Genetic testing is really, we're looking through a pretty narrow window. You know, there's between 20 and 25,000 genes in the human body. And in the cancer genetics world, we're really only testing for about 30 to 35 for most cases. We go more broad on some cases and we go a little bit more narrow on others, but you know, we're not looking at every gene here. And when we don't find a gene, and when there is a family history of cancer, we think that family history, as well as the environmental factors that Brianne mentioned, are more likely to come into play for these families. You know, and when we think about family history, there are some limitations. There's you know, some impediments that I typically find when I'm doing these family histories and trying to collect information from patients. And that's one of which is just distance. I typically find that for first generation immigrants, their family history is largely cut off. Really depends on how frequently they visit their relatives overseas. So that's, you know, an example of geographical distance, but some families just don't keep into contact even when they live in the same town or the same state. So distance can mean a lot of different things, and it's sometimes really hard to get accurate information about family members who may have a cancer history. And then the other is just a lack of historian. I typically find that women in the family are better historians than men. Just tracking medical information, I find that, you know, better records are kept. Just someone in the family who kind of logs and keeps track of medical information is very helpful for many families with a cancer history. And then the other limitations that I wanted to talk about, specifically with a few case studies, are adoption, non-paternity, as well as egg donor and or sperm donor cases, which can often complicate family histories and sometimes shroud a cancer history that would otherwise be more apparent. So this is just a very basic example of an adoption. So those brackets over the red square represent an adoption. And
hey, Everett, I'm not seeing that screen.
oh, okay, that's interesting. Did it just cut out?
I mean, it's only on the information technology screen I'm seeing where it says Seattle Cancer Care Alliance on the top.
Interesting. Okay. Do you see that screen? That slide? The family history considerations?
No.
We haven't advanced.
Okay, it seems to have frozen.
Yet.
So I will stop sharing and I'll try it again.
There's usually a little directional button that you can share, advance the slides with in Zoom that pops up.
Okay. Can everyone see my slides now? Nod if you can see my slides. No?
No, just you.
Okay. You know, I could just not go off my slides for the rest of the time if that's okay with everyone.
I could pull them up since I have a copy of yours and share them for you if that would
Yeah,
help you.
that sounds fine. I'm not sure why this isn't working. It's also glitching out quite a bit. A lot of flickering.
No worries. We know that this is hard sometimes. We're all in a new kind of era in doing this stuff, so it's not a big deal. Brianne, you have his slideshow?
Yep, I just pulled it up. So I will share the screen, my screen of his screen.
All right, and I was on slide 8.
There we go.
Great.
You see a family tree with yellow circles and a red circle?
Exactly. All right, so this represents an adoption. The circles represent females, the squares represent males. This is the typical way that we take a family history and designate individuals in a family. So the individuals at the bottom are the children of the male and the female with that vertical line going up. Again, this represents an adoption. The red circle indicates a cancer history. So we don't know any history on mom's side of the family here. However, next slide. If that adoption, if we're able to track down the family history on mom's side, we can see that cancer diagnosis, we don't see any other cancers in any family member. So it's much more reassuring that when we do genetic testing on that individual with the cancer, that negative genetic testing most likely means there isn't really as strong of a hereditary risk for this cancer. And this is actually my family history. The square on the bottom left is actually me, and that circle with the red, that's my mom, and she was diagnosed with ovarian cancer. And so, you know, when we think about family history, finding out more information is better here, because we can really determine that the ovarian cancer in my mother really doesn't seem to have much of a family history of ovarian cancer. There's no family history of breast cancer. So when we did genetic testing on my mom and her result was negative, it's a little bit more reassuring to us that perhaps the risks aren't as strong being passed down to either of my sisters, for example. So it can provide a lot more information in tandem with genetic testing results. Next slide.
It's not advancing. Hang on. Here we go. There we go.
And that little yellow arrow just means that that's me. And then we're just going to quickly go through a few case studies here. All right. So the first case study, this patient came to our clinic at SCCA, and well, I should take a step back. This is prior to her coming to SCCA. She is actually an egg donor to a family friend that was attempting pregnancy back in 2007. So pregnancy was achieved, and then 13 years pass, and they lost contact with that family friend. The patient's mother was then diagnosed with ovarian cancer and was BRCA1 positive. So the patient tests positive for this high-risk gene associated with breast and ovarian cancer. What do we do now? And, it's such an interesting question because, we don't know where that family friend is. The family has lost contact with her. So as part of my role in this clinic, we can generate a family letter that includes the family history information organized into that pedigree nomenclature where the circles represent females and squares represent males. We can include that with the genetic testing results, and we can send that letter out to both the fertility clinic that helped her achieve the pregnancy, as well as to other family friends that believe that they knew where this individual was. She was eventually able to be tracked down and also was found to have the BRCA1 mutation, which qualified her for high-risk breast and ovarian cancer screenings. All right, next slide. All right, yeah, thank you. So this is another case example. A patient came to SCCA due to a breast cancer diagnosis at 27, which is quite young. Her mother had a breast cancer diagnosis at 44, and genetic testing was negative in her mother. So this patient then tests positive for a BRCA2 mutation. And at this point, patient really questions her results. Are they real? Because her mom tested negative for both of these high-risk genes. Patient is questioning whether she wants to pursue a prophylactic surgical option like a double mastectomy. And at this point, the patient's mother discloses that her father is not actually her biological father. So this is a case of non-paternity. Interestingly enough, in this case, the specific mutation, the specific misspelling in the gene was more common to European populations, which means, which raised a few questions in this family because both sides were Filipino. And so that was the other piece of this equation that really caused this patient to question her genetic testing results, because the result didn't match her ancestry. And it was discovered that the father was in fact European, but also had Filipino ancestry as well. So we were able to reach out to this individual in the family and set up genetic testing in the paternal relatives as well. So there's a few take-home points from these case studies that I'll just briefly go over. Genetic testing is often empowering. In the cancer genetic setting, it can identify people who are at a higher risk of certain cancers, and we can get them in a screening program specific to that genetic change. However, genetic testing can cause a lot of anxiety, particularly in families where there can be things like non-paternity, as well as just facilitating communication to family members when there's a positive result. The other piece is that genetic testing doesn't always provide all the answers, and it really does have to be interpreted with family history. The more family history we know, the better. It really helps identify risk when genetic testing is negative. So this is really at the point where I want to turn it over to a Q&A, you know, and feel free to, you know, type in the text chat or however we want to do this. I think I'll go ahead and hand it back over to Brianne. Or
So if somebody doesn't want to, you know, be shown or be public, you can type your question in. I see Cassandra has, and I can read that. Or if you want, do you want to ask it outright, Cassandra? I'll ask it. Oh no, she's talking about history. I have a question for Brianne and Everett. So I'm curious, I did a DNA test 19 years ago because it turns out there was a genetic, I want to say malfunction, but that's not the right word. One of my aunt had a child who's disabled, and one at the top of one of her genes had broken off, and they had switched, and it was called a balance switch. And when my cousin was born, my mom refused to test. So my aunt reached out to me when I was pregnant with my first child to say, hey, your mom never tested. I don't know if you carry this. You should be tested. So I go in, I think it was the one in DC. At the time, there was only 2 in the country that were doing this, and get tested. And they ask, of course, my history. And I say that I am half African American because that's what I was raised to believe. Now I know that I'm not. I'm actually half Jewish. Do they have an ethical obligation? I'm not sure at the time. They could have known that. Were they testing for ethnicity? My guess is maybe not. I don't know. But it does make me wonder, and even now in today's day, and you know, if a client goes in, just like with your case study too, Everett, like that's a difficult dilemma. Uh-oh, that's not your dad. Do you both feel that genetic counselors have an obligation or are ethically required to tell the person that information?
So this comes up a lot in our profession, starting in training, in our graduate school training. Discussions about what to do in situations of non-paternity come up. And what we are trained to do is to make sure that every time we're doing the informed consent process for a test, that if something like non-paternity could be discovered, that we bring that up at the initial appointment before the testing even gets ordered. And that way, if this type of information could be revealed, that it doesn't come as a surprise to everybody afterward when it comes out at the end. Now, the ideal world doesn't work quite the same way as the envisioned way of how everything would work great. And until recently, there were no resources for families that discover that a non-paternity finding is discovered. That's changed in the past couple of years with all of the NPE groups that are now available. So there's support, there's resources available now. So it's a very different world than it was even 5 years ago. And I do think that there's an ethical obligation to disclose that information, and how it comes out depends on a lot of particulars with each situation. So if the child is 1 year old versus 12 years old versus 18 versus an adult, who's the first to be notified? How does the news come out? You know, who's the patient in front of you, and how do you bring up this type of finding? And there are some tests that will reveal paternity or suggest that there's something not quite adding up, but we can't always tell very easily from many of the genetic tests who the father is of that individual, or the mother, you know, if it's a egg donor situation. Yeah, I do think there is an ethical obligation, and I'm giving a talk next month to the National Society of Genetic Counselors, and one of the points that I'm making in my talk is the default in the past has been not disclose unless it was agreed upon that that non-paternity was going to be disclosed if it was discovered, and now default the other way, that this is important information. We need to default to disclosing, and at that same time, make sure we provide information about all of the support that's out there now, because not all the genetic counselors are aware that there are NPE groups and what that means, that NPE, non-paternity event, or not parent expected. So I do see things trending in that direction.
Yeah, and just to piggyback off what Brianna said, I do think there is an ethical responsibility to do good and to do no harm. Those are kind of the two main, I guess, what our profession kind of lives by. And you know, we always have the option in the clinical setting of writing things like an anonymous letter, providing resources to the patients that can be easily shared within the family members, that just really facilitates communication in general. Being able to just lay things out very simply and in writing that can be shared, I think is one of the most valuable things that can happen for these families.
Thank you, guys. I know that's a difficult thing. We have a question. What are your thoughts, recommendations? Ooh, it keeps moving, sorry. What are your thoughts, recommendations regarding genetic history for an MPE who doesn't have any family history from their biological parent?
So they're looking for a recommendation for genetic testing?
Yeah,
Or?
so what are your thoughts if someone should get genetic testing if they are an MPE and they don't have family medical history from their newly discovered biological parent?
Yeah, so there's a couple of different categories of testing that I recommend to anybody, no matter their level of family history that they have or don't have. One of those would be carrier screening to find out risks for carrying recessive conditions. These are things like Tay-Sachs disease, cystic fibrosis, sickle cell anemia, conditions that you're not at risk for having, but your children are if you and another carrier meet up and have a child. So family history is not going to give us any, usually does not give us any information about recessive conditions. And so we really rely 100%, nearly 100% on the recessive carrier screening tests for information about that. So that's one for anyone, regardless of their level of family history. There's a relatively newer kind of test called a proactive health screen. And this is a screen that includes genes that if we know there's a change in them, there's something you can do proactively about your health. So it includes cancer risk genes, cardiovascular disease risk genes. It's for anybody, no matter whether they have that in their family history or not. And there are a couple of different companies that offer them. Invitae is one of them. There's a couple of other testing companies. It does require having a medical provider involved, so it's not quite the same as going the at-home route with Ancestry or 23andMe, but it is a clinical grade test that can give you information that you can take to a doctor and say, hey, my result was positive for this, what can I do about that? So the proactive screen is another one that I recommend. And the at-home tests are not terrible. They just have big holes in them. So if you understand that when you test at 23andMe, it's just a very narrow slice of your DNA that they're looking at, and that's true for the other at-home test companies as well. All of them are going to give you a little bit more information. And if you do all of them together, that's kind of the most full you can get your toolbox.
So somebody asked this question. Everybody always asks this question. I'm not sure there's enough studies on it. What's your best guess for the percentage of the population that has an MPE, a misattributed parentage experience?
So I've talked with a number of genealogists that are in charge of large numbers of kits for their family. And I'm talking like genealogists that have like 20 or 50 kits that they're responsible for. And once you get to at least 10 to 20 kits, almost always there is at least one surprise finding, and it's not always that dad didn't know nobody knew that dad wasn't dad. There's situations of an adoption that happened and no one else in the family knew about it. There are situations of sperm or egg donation that nobody else knew about. So NPE is a really wide umbrella, and I estimate that it's the 5 to 10% range. That 10% number comes from a genealogist who runs a number of Y surname studies. So these are DNA studies where someone has their family tree built and a male in the family does a DNA test to specifically look at their Y chromosome. And the Y chromosome and your last name should match up along a family line, as long as everyone's dad is their biological father as suspected. And according to this genealogist, that about 10% of people who want to enroll in this surname project, their Y chromosome is not matching the last name the way that it should. So that means somewhere along the line, whether it was known or not known, somebody's father was not biologically their DNA father. So it's in my experience, in that 5 to 10% range. It's really hard to study because nobody's gathering the data. The DNA testing companies are not, for obvious reasons. And also not everybody who makes an MPE discovery ends up reaching out to the DNA company to say, your test gave me this surprise information. So it's really hard to study, because also, how do we define NPE? Do we keep that very narrowly defined as nobody knew dad wasn't the biological father except from the mother? Or situations where a man raised a child knowing that child was not biologically related to him. So it might have been a surprise to the child, but it wasn't a surprise to the dad. So it gets really tricky to put exact numbers on it because of all those different factors.
Absolutely.
Thank
Definitely
you.
a hard thing to nail down. Cassandra, did you want to ask a question?
Yeah, I was wondering if you have a sense of how much doctors are aware of this, just general doctors or even specialists are kind of aware of the genetics, because I also found out I was half Jewish, just like Cara and Alicia. And so we know in our group a lot that people are going to their doctors, newfound half Ashkenazi, and some of their doctors are saying, well, you can't inherit the BRCA gene from your father, giving false information, things of that nature, or not aware of the risks. And so I'm wondering what you know about, or what doctors are told, or if there are efforts being made to make doctors more aware of the needs of adoptees or donor conceived people, or just more aware of what genetic probabilities are for various diseases and cancers.
Yeah, and that's a really good question, and something that I see quite frequently, because a lot of our outside referrals are coming from either primary care physicians or other oncologists, and I find that it's uneven for primary care physicians. However, there are national guidelines which I would say that most oncologists and primary care physicians know about and are supposed to follow. They're the National Cancer Care Network guidelines, specifically for a cancer setting, at least with me. And, if there is Ashkenazi Jewish ancestry, there's a much higher chance that testing could be positive. There are specific mutations within the Ashkenazi population that we find. And so, if there's a breast cancer diagnosis, that could qualify an individual to be seen by a genetic counselor with Ashkenazi Jewish ancestry alone. So, I would say they're supposed to be following guidelines. That's not always the case. I would say it depends on a lot of different factors, like if the physician is in a more rural setting versus in a large city, there may be some gaps in understanding that sort of thing. Part of my role as a genetic counselor is to sometimes do talks to other healthcare providers to raise awareness that genetic testing should be warranted in certain situations, and a genetic counseling referral should be warranted.
So I think we're going to go ahead and let Tiana ask her question, and then I think we're going to have to move on. There hopefully will be time in the end for more questions. Tiana? Oh, you're muted.
You're muted.
Thank you so much to both of you. So my question is, do donor-conceived people that are seeking their genetic family, do they, in your sensibilities so far, having worked with them, do you feel like they have seen stigma when contacting genetic family members? And how have they overcome that? And have your facilitation efforts, I heard you say that you've sometimes wrote letters. Has that helped to mitigate the tense relations that may be there, and recognizing that that's not always the case with donor-conceived people?
So it's a big question, and I'll kind of answer it from my experience working with all sides of the surprise trio, I guess you would say. The experience of the discovered or the found biological family depends not only on the individual who gets contacted first, but on the way the news spreads through a family. So if the DNA test finds a first cousin to the donor conceived individual, and that's where the family contact starts, and the sperm donor father is not aware that this sperm donor conceived child of his has been found, and then the news spreads through the family kind of in a ripple way instead of getting directly back to him, it can be a lot harder to kind of come back around and get everyone, get that communication smooth between parent and the donor. Versus when a sperm bank is involved at facilitating that contact, it's direct, and it's not online. It's not out there for the rest of the family to find. And so each situation is very different and depends on just the way the news comes out, and then also the individuals involved.
Great, thank you so much. Alicia, you want to introduce our next speaker?
Yes, we've got Jody coming up to speak. She's an attorney and is an author and professor from Indiana University and has written a couple of books. Jody, are you ready to go?
Yes, I am.
Perfect.
Sorry I was not on earlier. I had some sound difficulties since I had a Zoom update, and we all know where those lead. Thank you very much. And so I am an expert on two kinds of fertility fraud in general. The first is basically what we call fertility fraud, what the main topic of fertility fraud has come to represent, and that's when doctors use their own sperm to conceive individuals by primarily in the 1970s and 80s against their patients' consent. And so we now have approximately 18 to 20 cases that have been filed in the United States. We have one case in Canada, additional cases around the world. And to date, no doctor has been criminally prosecuted for doing this. And we also have a different kind of fertility fraud, which is, it's hard to call fraud per se, according to the legal definition, because we don't know exactly why some clinics don't follow up with certain donors, don't examine all donors' characteristics, but I'll be talking about a case called the Zytex case as well to illustrate this second category, which could also cross paths with fertility clinic negligence. And so I'll start with the fertility fraud cases. And so, and as I understand it, I have about 20 minutes, is that correct? Okay. So fertility fraud, I'm probably the national expert on this due to a doctor who was about an hour north of me called Dr. Donald Klein. So Donald Klein, in 2014, it came to light that he used his own sperm on patients beginning in the 1970s and 80s. When I started interviewing his donor-conceived children and his patients, there were 23. Now there are 76 of them, and they inherited genetic conditions, as have many other doctor-conceived children. And so at this point, the Klein case was really just the warning bell of a fact pattern that would be all too common pretty soon. In this fact pattern, an adult takes a direct-to-consumer test like 23andMe or Ancestry.com and gets the results back only to find out that she has many half-siblings. And many of these individuals did not know that they were donor conceived at that point. None of them knew that their actual biological parent was their mother's fertility doctor. And so there's a bit of legal wrangling that goes on there. And, you know, they try to ascertain whether they can sue the doctor. They try to talk to their parents about the circumstances of their conception. Their parents might not be forthcoming that they were donor conceived, and so that might lead to further family fragmentation. And in the meanwhile, they're being matched, you know, through their genetic test to a number of half siblings, which either could be other doctor conceived individuals or other relatives, like, for example, the acknowledged children of the doctor themselves. And so there's a lot of communication issues as well. I mean, so sometimes if you have existing half siblings from the same doctor who are also unacknowledged doctor conceived children, they'll reach out and they'll sort of bring people into the fold and share the story, break the news gently. You know, they'll share news articles, for example, if other people have been public. Otherwise, the first one to contact might be a relative of the doctor in a few cases. And it'll be like, who are you? You know? And this is an interesting conundrum because people don't necessarily know who they are. They have no idea who this person is contacting them out of the blue, who's suddenly a first cousin. They don't know, as we've talked about before, why this person with very different genetic ancestry is suddenly related to them. And it's a traumatic mystery. And so what usually happens in these cases is that they learn, the doctor and the couple, basically the doctor and their parents agreed when they underwent artificial insemination, anywhere from, I would say 2 times to over 20 or so times, that the sperm that was going to be used would be from a medical resident resembling the husband. And so in a few cases, the doctor promised the parents that the doctor would ensure that the husband's own sperm would be used or would be mixed with that sperm of a donor to increase chances of conception. And so what we know is that that's blatantly false, right? In some cases, the husband samples were never used, could never have been used. In others, you know, we know that this was not a medical resident, it was actually the doctor himself. Of course, when people find this out, this is tremendously demeaning. It's like it's being compared to learning of sexual assault or rape decades later. And for the parents, you know, as I said before, they feel like they were raped or violated. They feel as if they're in a really tough position because if they try to hold the doctor accountable, or if they feel that the doctor did something wrong, then they feel in a sense that that's betraying their child whom they very much love. And so it's very hard for the parents to learn to separate the idea that their child is loved and could not be a better child from the idea that the process through which this child was conceived was very problematic and fraught and was indeed, in fact, criminal. And so some parents just can't handle that. And what they do is they withdraw from the process, and their doctor-conceived children are left saying, hey, I feel violated. I feel like my parents were violated, but my parents don't feel violated. And that, you know, puts that adult child in a very difficult position. Identity-wise, it may lead to consequences such as the parents and siblings who might be from other donors or might be from the social father, may feel as if any attempt to reach out to new half siblings is a rejection of the family in which they grew up, and of course, again, further family fragmentation and further identity issues. The adult children also may have legal issues holding the doctors accountable if their state has not passed a fertility fraud law. So thanks to the efforts of Eve Wiley and others, we've successfully passed laws in 4 states now, specifically on fertility fraud. Indiana creates a civil and criminal cause of action for fertility fraud that expressly allows doctor-conceived children to sue, whether or not the parents choose to sue as well. Texas takes a slightly different approach. Texas has a sex assault law that says it is sex assault if a fertility doctor uses his own sperm to impregnate a patient without that patient's consent, and it has a registration requirement. Of course, it's a criminal law, so it cannot be used to prosecute doctors that did this in the 70s and 80s. It could only be used going forward because of criminal law doctrine. And other models in Florida and Colorado also are closer to Indiana and carry some additional reporting requirements. So there is speculation as to why a doctor would do this. Many of them, I'm sure, have narcissistic tendencies or personality disorders, but I'm not a psychologist, and to my knowledge, none of these doctors have been psychologically evaluated. They all claim, for the most part, that they were trying to help desperate patients, and that, but for their sperm, these families would never have conceived the child that they love. But then they get into some other weirdness. So for example, a client actually met with his doctor-conceived children at a restaurant in Indianapolis when about 8 of them got together with him. And he started quoting the Bible and said things like, "I knew you in your mother's womb." And so obviously there are some different issues going on here that we really can't speculate on, but that appear to be deeply problematic and, again, traumatic for the identity of these individuals who are now related to the doctors. We do know that the standard of care at the time said that this was blatantly unethical. First, it was a violation of informed consent because it directly contradicted what the doctor said was going to happen to female patients. Although it was standard practice to tell patients not to discover donors' identities well into the 1980s, even into the 1990s, of course, this bears differently when you're covering up your own crime. In addition, male infertility was heavily stigmatized at this time, and wives who underwent this procedure didn't discuss it with their husbands, didn't discuss it with their friends. This is something that just sort of happened. And so it's no secret that the genetic tests now have revealed many, many inconsistencies, this, of course, being one of them. Interestingly enough, it's different for lesbian couples than for heterosexual couples. And so the practices around that time, if you have a doctor-conceived child and you're a lesbian couple, it might lead to a different pattern of conceptions for your doctor than for a doctor who certainly only helped heterosexual couples. So for example, Klein did not help lesbian couples, was very religious, said explicitly, "I will not help you." So his victims are primarily in the Indianapolis area. However, Paul Jones, who's being sued in Grand Junction, Colorado, has a different pattern. And so if a doctor like Paul Jones helped a lesbian couple, that lesbian couple would get on the phone with other lesbian couples who then were looking for doctors who would help them to conceive. And they might travel from all over the country. And so when you have a fertility fraud case, like Paul Jones, for example, you very much want to make sure that there's publication opportunities and others, and notice opportunities for others around the country to find out about this case. That becomes very important. So the other case I want to talk about very briefly is the case of what happens when a fertility clinic promises it will screen and doesn't screen as well as it can. What do courts do? And so these are some of the consequences of the doors that genetic tests can open up. So there's a very well-known case called Zytex, the Zytex case. It's a Zelt versus Zytex. It's a Georgia. It's currently before the Georgia Supreme Court. What I'll talk about today is actually a lower court decision. The court decided to rehear the case, and we're currently awaiting for a new decision. Hopefully, it will be a different decision. But in the Zytex case, so Zytex is a large sperm bank, and there was a family called the Zelt family who wanted to have children. And on its website, Zytex made a number of promises. They said, we're going to give donors a physical exam every 6 months. We're going to interview donors. We're going to conduct psychological assessments, all to help, you know, couples make the most informed decision. And so when the Zelts looked on Zytex's website, Zytex said, well, check out donor 9623. And they've made direct promises to the Zelts that donor 9623 had a bachelor's and master's degree, that he had an IQ of 160, which is like super genius status, had a near perfect medical and mental health history, no criminal background, and was a sought after donor. And in fact, they said that his sperm was rarely available, but you're lucky you called today, and so we have some. And so the Zelts underwent artificial insemination twice with donor 9623 sperm and had 2 children. But it turns out donor 9623 is James Eggley's, and his characteristics are very different. And as the court case says, a man with characteristics the Zelts find highly undesirable. He had been diagnosed with paranoid schizophrenia, narcissistic personality disorder, a drug-induced psychotic disorder, grandiose delusions. He had been involuntarily hospitalized for mental health reasons. He had been disabled due to his mental health condition. He had a criminal record. He had been arrested for burglary, disorderly conduct. He had no master's degree and, in fact, no PhD program. And he only earned a college degree years after the Zelts purchased his sperm. And so he lied on his written questionnaire to Zytex about his educational achievements. And in fact, there are some allegations in the court case that when Eggley's told a Zytex employee that he thought, my IQ is about 130, the employee suggested to him, well, I think it sounds more like an IQ of 160. And so because the Zytex informed Eggley's that more educated donors were more successful and encouraged him to lie about his education. And so Zytex could have determined at any point that these representations were not true. With a simple internet search, for example, they would have found his physical characteristics were not as he portrayed. His physical exam with the sperm bank only lasted 10 minutes. No examiner discussed his physical or mental health history. He was given no psychological tests. The sperm bank never requested medical records, never even asked him to sign a release. Never asked about his criminal history, never asked him his ID. And so, of course, the Zelts learned this after they had 2 children, and they sue in federal court alleging various things, including, fraud, misrepresentation, emotional distress. And their claims basically were about, hey, and they're difficult claims, we would have preferred children from a different donor. Right. So they're saying the children we have now stand to have issues that might show up as they age, like mental health issues, that children from a different donor, from a non-negligently selected or represented donor, would not have had. And it's a difficult claim again. It's sort of like, what the parents go through in fertility fraud situations when they're asked to compare, a potential child from their husband or from an anonymous medical student from the actual child they had from the doctor donor. And so what the court did is they said, we can't help you at all. Even though the clinic did something terrible, they said, we're really sympathetic to what you went through, but basically your children appear healthy. And we can't calculate the value of the child born from Eggley's, and we can't compare that child to a hypothetical child that would have been born from a donor with different characteristics. And so basically, certainly before any mental health history, any mental health conditions appear, they ask that, the court basically says, we can't reward, we can't give you an award either for emotional suffering or even fraud solely on the basis that your children might have different characteristics than you planned. All of this has a lot of consequences. The courts feel sort of tied, I think, by prior case law that says the birth of a healthy child is not a harm. And certainly these have, the positive consequence is we avoid stigmatizing conditions like mental health history, but at the same time, the clinic did something horribly reprehensible and in a sense got away with it. And so there is very little incentive now for courts to, for sperm banks to decide that they're going to follow up on health history, to decide that they're going to be above board about what characteristics donors have, or even to do due diligence with donors. And so we're very much hoping that the Georgia court comes to a very different decision and says, yes, this is an injury that for which we can compensate families that are in this situation. And I think there are about 36 families, by the way, in Egley's situation. And there's various permutations of, sperm bank claims. A lot revolve around certain health conditions, such as autism, such as heart conditions, genetically inherited heart conditions, such as learning disabilities. And, again, it reveals, how difficult it is just to hold sperm banks liable legally, and in a regulatory sense as well, because they set their own policies and really hold their feet to the fire to make them do due diligence. So, I think when we look at this, we can look at these two cases differently. They're, on one hand, we've known about sperm clinic deceit for a long time. On the other hand, cases like fertility fraud present new conundrums that we're just starting to move through. And we're encountering questions like, who has the right to sue? For example, in one case, Mortimer versus Rowlett, which is in Idaho, the court determined that the parents could sue because they were the patients of the doctor. But yet the doctor conceived child herself could not sue because she was not a patient of the doctor, and therefore could not have been harmed. And that's a manifest injustice. Her identity was traumatized, was affected very much by the doctor's conduct, and the doctor, that was foreseeable to the doctor at the time, right? It was entirely foreseeable to Klein when he did this, and I'm assuming that 76 children isn't the upper limit of his efforts as either. That not only would it be traumatic to his patients' children's identities, but that these people would grow up in Indianapolis together, and they would meet each other. In some cases, they went to high schools together. They lived down the street from one another. And it's very easy to think of a case where you could have dated your half sibling without knowing that person was your half sibling. Again, deeply traumatic, and it doesn't even carry consequences only for the doctor conceived children and the parents. The grandchildren. Do you have to genetically test your grandchildren in Indianapolis, before they start, or when they identify a significant partner, so that you don't know, so that you can rule out a tie to, Dr. Donald Klein. And so, again, what's most frustrating to me is the point at which sperm banks and the doctors themselves can sort of thumb their nose at the rest of us and say, hey, we were acting for the good of patients. We were acting to produce, loved and wanted children. And so they use that, not only the idea that patients were desperate and would have accepted anything that came down the pike, but also that they had the ability to subject people to unethical and unconsented to procedures, or to lie or misrepresent characteristics in order to advance reproductive goals. And so that is, I think, an absolute irony, right, of a healing, helping profession such as reproductive endocrinology. And we need to work together, to make this a reality, to make regulation a reality, to make transparency a reality. And one of the last thing I'll say, because I'm coming up on the end of my 20 minutes, is that these cases, they don't stop. And so there's a case out of Australia right now, Australia and several other countries, where there's a donor who donates underground. He travels around and donates for Bitcoin. He basically is donating actively. He's banned in the Netherlands. He currently lives in The Hague. He may have as many as 1,000 children. And they're just starting to learn, even though he's been banned in the Netherlands, that information is not given to other countries in Europe because there's no, Central European registry. And oftentimes when these underground donors are banned from one clinic, they just go to another, give different information, and they're back in business. And so this guy is like a sperm tourist. I would say he's more like a sperm terrorist. And he goes from country to country, helping people out, and is very open about this on Facebook, will, totally talk to parents until they criticize him and ask him to stop donating, because they learn that their children have, upwards of several hundred siblings. And so, by the way, the 1,000 children is his record. There's also a donor underground in the UK who proudly remarks that he has 800 children. He meets couples off the MH highway right outside of London, and gives them a sample and shows them, a little piece of paper where he's been tested. And that's, again, just like the sperm banks who are following their own policies, these underground donors who are going rogue, they may have their own policies or protocols, but certainly they're not what we want. We need a comprehensive regulatory scheme on an international scale that tracks donors' identities, that more stringently penalizes clinics and practitioners who lie and defraud their patients. So I'll stop there.
Thank you, Jody. That's an amazing overview. So much information. We have a question, Alicia.
Yeah, this is from Libby Copeland. This is her question. She says, my sense is that fertility fraud has lessened since the 70s and 80s. Is that the case that we know? And if so, can you explain how it's related to changes in how sperm is used, fresh over frozen?
Yes, so for the most part, the cases began in the 1940s and 1950s, and there are some that are not public that, certainly the English, cases are more public than those in the US, but there are some unacknowledged cases in the US that were existing in the 1940s and 1950s. And then we sort of have to assume it's happening in the 60s as well. When it gets to the early 70s and 80s, that's the real, I think, timeline for most of these fertility fraud claims. And most doctors stop when they're around 1987, because that's when requirements that sperm be tested for AIDS and other STDs were put into place. And of course, in order for sperm to be tested effectively, it has to be tested across a series of times, right? If you're a sperm donor. And so one of the most interesting things is that there are some doctors that continue afterward. There's a doctor that continued donating in the 1990s, and there's a doctor that continued donating in the early 2000s. And so, but that's not the mainstay. My favorite doctor is Dr. Kim McMorris in Texas. We filed to take away his medical license, and we're currently awaiting the outcome of that procedure. Dr. McMorris actually said, well, they froze my sperm when I was a med student in the early 1970s, and I just recalled it, in the late 1980s, when I found out that the patient's sperm from California Cryobank had low motility, and it wasn't great. It was not a viable sample. And when we actually testified before the doctor's medical license hearing, I kind of had a field day with that, because I was like, either he's lying, because no one froze doctors' sperm or med student sperm in the early 1970s. Very few sperm banks even existed, even commercial ones. And why in the world would you use a donor sample that was 15 years old, 16 years old, that was frozen according to this very outdated technology? So I liked seeing him squirm there.
I have a question for you, Jody, and I'm putting you on the spot a little bit, so I apologize for that. But and I think I've told you before, some of you guys know, I've been trying to change my birth certificate, and under the new Uniform Parentage Acts, the thinking is that you can say, well, on these over-the-counter DNA tests, I learned that my dad isn't my dad, and so this could open the door to the courts to go ahead and do formal DNA testing. However, Ancestry just updated. I don't know if you've seen this. Do you know what I'm talking about? They just updated their terms of service. It started September 23rd, and it goes into effect October 23rd. And so some people are very worried for my case, because unless it gets filed and goes forward before October 23rd, they're afraid that I might get kicked out of Ancestry, which by using their data. And I think this is going to apply to a lot of different cases, not just my example, but I'm going to go ahead and read what it says so everybody knows what I'm talking about. It says, you will not use the information obtained from the DNA services in whole, part, or combination with any other database, any medical, diagnostic, or paternity test. So we're also talking about genetic counseling here too, in any judicial proceeding or any other discriminatory purpose or illegal activity. So this takes effect October 23rd. So basically, I'm interpreting this that you couldn't use even their health side to say, hey, I need to go see a genetic counselor because I got this data. Hey, I want to file a legal document. I want to open the door. You're not even using it as the basis, just as a open the door. What do you think? What's the ramifications of this?
I think that they had to have it in there, but I think that is very, very dangerous language for us. And so because it has a chilling effect on people's willingness to take these samples and use them as the basis for any other claims. That said, so something similar is actually happening. Sperm banks have, you guys might have heard of the Tusher case, where a woman who, I'll keep this brief. The elevator version is a woman chose to submit her 5-year-old daughter's test materials to Ancestry. Her 5-year-old daughter was donor conceived. She got matched up to the donor's mother and contacted the donor's mother, and then Northwest Cryobank reached out and said, oh, we're going to fine you $20,000 and we're going to take away your remaining sperm vials, and we're going to kick you off the forum for parents, related to this donor because you reached out and contacted the grandmother in violation of policies. And the problem was they didn't tell people what contact meant. The grandmother could have easily reached out to this new person who came up on her Ancestry relative list, and perhaps the same result would have obtained. Moreover, this suggests that anytime we connect with others and ask about health history, what does research mean, right? In what proceedings are they talking about? So, and this information can't sit in a vacuum, right? This information has legs. It's going to make people talk to one another who didn't know they were related and now know they're related. And sometimes those relationships are going to entail legal conundrums, affairs, fertility fraud, negligence, whatever the case may be. My guess is that they're going to be unenforceable. But what you're going to want to do is say, okay, I got this, and I'm going to immediately turn around and get a full-fledged DNA test as soon as possible, because that way, although this raised the specter, I would basically never file suit based on 23andMe alone without also asking for a paternity test. But if it makes you feel better, in all of the doctor deceived cases, when they filed suit, they always alleged like an Ancestry or 23andMe connection. And they're alleging this to get the doctors to take a paternity test or a DNA test. And in none of these cases has 23andMe or Ancestry ever said, no, you cannot use this information.
But I think they will now.
They might, but at some point, the next legal claim is going to be, I paid for the test, it's my information, I have the right to use this to enforce a claim, or as a stepping stone. And so, and if I don't think that 23andMe or Ancestry will be successful in those claims, because they can't put the DNA information out there and draw an artificial wall around it,
It does make me wonder. I always think behind every rule there's a reason. So I do kind of wonder what happened with Ancestry to make them come forward with this. Because I do, right? But I do think, it does, these sorts of over-the-counter DNA tests do open the doors for requesting genetic information, or for the courts to step in to do the more official forms of testing. And without that, I do think it will have a chilling effect. So yes. Does anybody else have any questions that they would like to ask of any of our 3 panelists? I noticed in the chats, people were talking about a catch-22 with the genetic information for the genetic counselors. I wondered if either of you guys had anything to say about that, where you can go ahead and have testing or genetic counseling paid for by your insurance if you have a family history. But if you're an MPE, donor conceived, well, MPE, donor conceived, or adopted, you don't have a history. So do you guys know if insurance companies will still allow genetic, cover genetic counseling in general? Obviously, we're asking for people who don't have medical histories.
So typically, if someone doesn't meet criteria, but a doctor recommends a certain test, the insurance has to cover it or is obligated to cover it if it's doctor recommended, regardless of the history. So one piece of advice I would have is to do some research to see what are the requirements for genetic testing coverage by your particular policy, and are there ways to, are there doctors who recognize that adoptees, NPEs, donor conceived people are at a medical disadvantage for not having family medical history, and have an appointment with a doctor that understands that issue and sees the value in ordering genetic testing.
I just wanted to quickly state that the guidelines are becoming a lot more adept here, and at least some of the breast cancer guidelines are now stating that if there is a limited and or lack of family history, sometimes that can qualify patients for genetic testing.
That's great in the UK, Joanne. I'm glad that the NIH let you do that, or NHS. I know you guys have a little bit better coverage for medical things than we do here.
Exactly. I thought the same thing. I thought the same thing. Well, I think we're about to wrap it up here. Does anybody else have any other questions?
Can I make one more point?
Sure.
So I think that when you look at the specific case of fertility fraud and the doctor-conceived phenomenon, I think that the doctor-conceived is one small subset of a larger donor-conceived, community. And I think as these cases evolve, there's friction between a lot of the doctor-conceived individuals and the donor-conceived individuals, because the doctor-conceived individuals have gotten so much media attention as of late, and they're on the talk shows, they're in newspaper articles, and one of the things that we're working together in the doctor-conceived community is to consistently draw parallels between what they undergo and what other donor-conceived individuals undergo, and not knowing aspects of their identities, and in fact being robbed of several things, by clinics, by by a lack of knowledge, by several factors. And so I think to the extent that we can, use any amount of publicity to shed light on these issues together, and to take more of a children's rights or donor rights perspective on these issues, I think that would greatly help, both communities.
I wanted to also say thanks to Brianne, because I think you were discussing about recommending that we lean towards the other way as a default, that we talk about these things to people for genetic counselors, and you're going to go next next week and reiterate that. And I am so appreciative of that, because I think that if we all reach out in all of our various ways to try to push the ball in that direction, where we talk about these issues and educate everyone on the problems that they cause, hopefully we can find the services and resources that we need. And so I'm really grateful that you're doing that, Brianne.
Thanks.
Alicia, you're on mute.
I'm sorry. I'm sorry about that. I keep getting this mute and unmute in my head wrong. I really, Brianne and Everett, I'm so grateful to both of you guys for coming on here, because I actually have been to, I have talked to both, I go to the Seattle Cancer Care Alliance, and I also have met with Brianne too with my own medical history. So I'm very appreciative that you guys came on. Jody, your talk on all this was unbelievable. There's so much I learned from what you just said. And so much more for us to have that we need to do for the NPEs in general, and for legislation. And that's the one case you brought up about Dee. We have personally been working with her on that case, as you know, and hoping and praying that it moves forward in the way we would like to see it move. If I think we're about done here. Does anybody else have any other questions or anything else that pops up? I'm so appreciative to all of you that just popped on to listen in with these wonderful speakers we had. We have another one coming up that we'll put in the private groups, and that is going to be hosted by another board member, Tiana. I think, is she still here? Did she pop off already? She may have, because she may have had to go back to work.
Yeah, so it's October 18th at 4 p.m. Eastern Standard Time, and we're going to be talking about trauma, identity, grief, and loss and anxiety around MPE issues. So look for more about that coming.
Yeah. Thank you guys, everybody. I really appreciate this. Oh, I think Tiana's trying to come back into the group. Let's see if she wanted to say anything else. So, but I appreciate everybody from coming here and taking your time. Tiana, I was just announcing about your webinar you're going to be having here pretty soon, and then Cara mentioned it.
Yes,
so
thank
that'll
you.
be next on the agenda for us. And from us, from Right to Know, we appreciate you coming. If you have an opportunity to go look at our webpage, I would love to see you pop in on there. Any suggestions you have for us? We're working soon having a app that you will be able to go into. That should be out, I hope, within the next month. I always tell Carl, I said, we got to move it faster. Anyways, thanks everybody for being here.
Bye.
Bye, everybody. Thank you so much.